Thank you. Good afternoon, all of you. This is going to be very quick. We are going to talk about heart failure. The first half I will be touching upon, and then Dr. Srinivas Kumar will be following up with the second half of the presentation. So basically, the theme of this about half an hour discussion is going to be, how do we maximize home time in patients with heart failure? And this concept is something that came up recently. We always used to talk about hospital admission or the amount of time the patient spends in the hospital. When we look at from the other side of it, we are talking about how much time the patient spends at home. And that would also include the fact that they would come for frequent hospital visits or whatever medical contact they do. So you take all of that out and get the concept of percentage home time. So if the patient is admitted 10 days in a year, then out of 365, 355 days will be the home time versus 10 days they're spending in the hospital. This is our thought process that we have been working so far with, which is heart failure being a leading cause of mortality and readmissions. And the more the readmissions, more is the mortality. That part is quite well understood by all of us. While these indices are quite obvious, it doesn't take into account all the spectrum of heart failure morbidity that we're talking about. And that is where this concept of home time comes. So it is defined as the time spent by the patient alive and out of any healthcare institute. So if a patient is coming to you, that doesn't count as a home time. So you have to ensure that whatever you are doing, maximize the patient's home time. This is also quite relevant because it is the most important patient-centric outcome, because that is what the patient wants. Patient wants to spend time at home rather than coming and visiting you every now and then. Home time reflects better patient experience. Obviously, it doesn't have to be studied in detail. Patient would like to spend time at home, not in the hospital. Why is this important? Now these numbers, they make more sense in the Western world, where between home and the hospital, there is also this mid-level provider, right? They'll have nursing home, they'll have rehab, they'll have all those kind of centers. In our setup, particularly in India, if a patient is not in the hospital, the patient is at home for most part. But if you look at the Western data, they would suggest that 30 days post-discharge patient, 10% of the patient has no home time, which means they are not going back home. They are going into some rehab facility or some mid-level aspect or whatnot, or nursing home for that matter. And a year after discharge, about a third of them, they are spending less than 50% time at home. A lot of the time they are spending in some sort of institute, getting some sort of therapy. These numbers, as I said, may not directly translate to Indian population because here our setups are mostly either home or the hospital. Successful treatment now, the matrix should also include home time, which means how much of a time a patient spends at home as compared to sitting in the hospital. So what are the determinants? And the determinants are quite obvious. We all are familiar with, if the patient is in the hospital, obviously that won't count as a home time. Mortality is quite obvious. The aspect of cardiac remodeling, elevated biomarkers, and all those things, they all contribute to reducing the home time, and we obviously want to highlight each one of them. So we'll go one by one. Impact of hospitalization is quite obvious. We have all learned that more readmission leads to higher morbidity, higher mortality, and obviously if you're spending time in the hospital, that means you are not at home. So we want to get these patients out of the hospital. And one re-hospitalization you prevent, you not only add to their quality of life, but you also increase their longevity. And this is something that has been honed upon us for quite some time. And this is the basic essence of GDMT that we prescribe to our patients. What we look at is from whichever angle, be it your cardiovascular death, all comers or whatnot, mortality, readmission, no matter how you look at it, every event causes significant morbidity and mortality to these patients. Impact of mortality is quite obvious. If some person is dead, that won't count as a home time thereon. So as we know that heart failure, they certainly will have higher mortality as the disease progresses and as you get more readmissions. So obviously, whatever we do want to reduce mortality if one of our outcome is home time. Cardiac remodeling, what we know is as the heart remodels in a negative fashion, it adds to the death and hospitalization, both in terms of diastolic or systolic volume, and that is again something we track objectively when we are doing studies related to drugs. In our routine clinical life, we may not be tracking the remodeling index as much, but the scientific evidence clearly suggests that the higher degree of negative remodeling increases the event rate. So the data would suggest that lower the ejection fraction, higher is the event rate. For every 10% reduction in ejection fraction, you'll get almost 50% increase in clinical endpoint. Biomarkers are also quite obvious. Patients who have got higher NT-proBNP levels, they have about 5 times increased risk of mortality and about 14 times increased risk of hospital readmission. So if our target is to increase home time, then obviously we want to reduce NT-proBNP. We are going to talk about the therapy part of each one of them. We are only talking about the variables at this point of time. Renal function, all the practicing clinicians here, they would know that when heart failure is combined with impaired kidney function, either transient or permanent, then that just complicates things quite further. These patients, they have got worsening outcome, both in terms of morbidity as well as mortality. So as we are talking about, we do want to preserve the renal function as much as possible, knowing that CKD patients, they do have a higher event rate. In the metabolism aspect, the most important parameter that we look is diabetes. And we do know that diabetic cardiomyopathy, particularly with every 1% rise in HbA1c, it definitely increases the risk of rehospitalization and by transitive properties, increases mortality as well. So amongst the metabolic parameter, we do know that HbA1c control is quite relevant in terms of heart failure outcome. Impact of quality of life, that kind of goes in hand with home time. That if you have a better quality of life, obviously you will spend more time at home rather than spending time in rehab centers and whatnot. So we also want to improve the quality of life so that they spend more time at home. It also has got direct relation to heart failure readmission. So home time is something that is gonna come up again and again as we increase our understanding about heart failure. Home time does have a direct impact on survival, and that goes without saying that if you are able to successfully keep the patients at home, they are less likely to have heart failure readmission or death or whatnot. So this is a clear example that if you have got, I don't know if you can see my arrow, but towards the right side of the graph, if you can see that more number of days a person spends at home, the lesser event rate or event-free days they have as compared to people who spend more time at home. So therapies matter, and we talk about how higher hospitalization causes higher mortality, poor quality of outcome, and all of those. So changing our focus a little bit about the heart failure therapy, not just about mortality and hospital readmission. Home time is going to come up as the new matrix as we treat our patients to keep them in the hospital, out of the hospital as much as possible.